Okay, I'm starting to share my screen. I hope. Yes. Okay. And what about recording? Okay, it's being recorded. Yeah. All right. Hello, everyone. Today I'm going to talk about sickle cell disease. This is a widely discussed topic in the electives, in the rotations. You're rotating under hematology, oncology. This is like the bread and butter uh, case that you would be looking at first day of your rotations, and so you need to know this. This is the basic things. So let me elaborate every single aspects on this particular and pertinent situation. Let's say, for example, there is a 5-year-old kid who presents to you with chest pain, shortness of breath, edema of the hands and feet, along with abdominal pain. You immediately think about sickle cell disease or maybe sickle cell trait, acute chest syndrome, infections, and so on. What is the first thing you would want to do in this patient? Firstly, you do the chest x ray. Okay. You do the CBC, BMP, all that. And then you can do hemoglobin testing, peripheral smear, and so on. And do urine analysis. Okay. Because we want to rule out hematuria. Blood cultures. Why blood cultures? Any patient who presents with a fever and WBCs going over 12,000, you need to do this. We are doing this to tailor down our antibiotic of choice. Okay. Then we can do PT, PTT, INR, blood grouping, and cross matching. Everything to do with hematology. Why? Because we want to make sure the coagulating factors are within normal range. Okay. So once the investigations have been ordered, let's go to the treatment. I like to connect the dots, meaning let's go over pathophysiology first. What is sickle cell disease? Mostly our RBCs are biconcave shape with a central pallor. In this case, it turns out to become a banana shaped RBC with reduced surface area. So, this will then circulate in the blood, making all the way to the spleen. In the spleen, there is auto-infraction over time. How does this happen? It's because of splenic cells accumulation. Over time, it can just be overwhelming, where the spleen can burst out to have auto-infraction. This is a devastating complication because following the infraction, the patient can be prone to encapsulated organisms and infections, which again is like leading cause of death in this individuals presenting to you with sickle cell disease. So not only this, it has several other complications. The sickle cells make all the way to the blood vessels, supplying peripheral organs, leading to edema in the hands and feet, or let's say ischemia because of loading sickle cells. Okay. And this is what we call as vaso-occlusive episode, or you can say vaso-occlusive crisis. Um, since the name suggests vessel and spleen are getting involved, leading to lot of messed up scenarios. There can be situations where the renal kidneys can undergo infraction, causing papillary necrosis, or there can be um, stroke where cerebral blood vessels can get involved. Every time a patient presents with the pain, there is a lot of uh, trauma behind the presentation itself. It is going to be a very pathetic situation to see. So, immediately you will admit these patients and start on morphine. Okay, get rid of the pain. Now, in order to knock out the sickling in the body, we always may want to hydrate the patient. Okay, hydration. This is paramount. Hydroxyurea to cause a conversion. This will also enhance the HBF production. Make sure to give folate. Folate is an important precursor for RBC cell production. So, you are basically potentiating the RBC production. If the RBCs are way too low, consider blood transfusions. And with multiple transfusions, you may want to follow up the patient and decide on iron chelating agents. And most of all, the best preventive order that you might want to add in is vaccination. Again, emphasizing the fact that these patients are prone to infections, vaccinate against all the encapsulated organisms, including Haemophilus influenzae type B. In terms of antibiotics, we like to give IV ceftriaxone. Also include prophylaxis here, penicillin B. Typically, it is given less than 5 years of age. However, if you have a 7-year-old, do not go thinking if you have to give penicillin or not, because we may not know that the spleen has infracted or is in the process of infraction. Regardless, we give prophylaxis to age group of up to 12 years, or let's say 10 years. There is another entity called sickle cell trait. This is something pretty good compared to the sickle cell disease. Most often or not, they may present with no symptoms at all, and it could be just a out of sudden situation. Okay, so meaning these big guys end up living a normal life. Make sure to include one more. Yeah, urine analysis. I finished that. Okay, so I'm going to stop here. This is all I wanted to come up with. I hope you are liking my content. And if at all you want me to discuss any complex topics, do let me know. And if you're looking to enroll in one of my tutors sessions, then please let me know and or reach out to me. I'm more than happy to help, especially if it is about CCS cases. So I'm sure you are well equipped with the key points on this case we discussed. And I hope you like it um, and find it useful. All right. Bye bye.